Great to be here, and I appreciate the invitation. I appreciate everything Edge for Scholars is doing here, plus all the other amazing infrastructure we have for developing research careers and doing great research. So first, a little bit of background. This is dealing with study design. Can we experiment till we have an answer? That's something we don't hear asked very often because we're taught to be very rigorous and have everything pre-specified, to have a sample size and a power calculation. But can we really be like physicists who really don't do many sample size calculations, but they experiment till they have an answer? And so that relates to the sequential nature of experimentation and how many samples that you need to analyze, how many patients you need to enroll. And if you want to act like a physicist, you would need a fully sequential approach to acquiring and analyzing data. But they're almost never used. People are afraid of fully sequential thinking, even though that's the way learning always takes place. So what keeps a researcher from collecting data until there's sufficient evidence and then calling it a day? So sufficient evidence in one direction, either safety problem with a treatment, efficacy demonstration, or demonstration of equivalence. So what's wrong with just going until you run out of patients or time or money? What's keeping you from doing that? Well, traditional frequentist statistics is what keeps you from doing that. And everyone has been fed a certain line in their training, including me in the old days, that this was the only way to think. Even though sequential experimentation has actually been around for maybe more than 100 years, it's just not used much. The other problem with thinking more flexibly is that our budgets are typically fixed, and they're typically tied to a principal investigator and a project. And so we have to have that project succeed or fail on its own, and that's how your grants are reviewed and so on. Instead of having a portfolio budget, because if you had a portfolio budget, you can mix and match and let things that are promising keep going, even though your original sample size calculation turned out to be not very helpful. So wouldn't it be more logical to direct more resources to promising studies and direct resources away from unpromising studies based on things like futility analysis? To me, the answer is pretty clearly yes. So this gets into the paradigm that we use for quantifying evidence of efficacy and safety and other things. What would you like to know? Well, the way statistics is taught and the dominant forces of statistics that began in the 20th century were of this first type. So they sought a very simple model. They sought calculations that can be done by hand, didn't need a computer. And so when you have a simple model, you could say, well, if the treatment is ignorable, so if the treatment does nothing at all, if it doesn't hurt you and it doesn't help you at all, what is our level of surprise with the data that we've collected? So that's the predominant way of thinking. And you can start to see the problem that gets into because you can be surprised at different times, at different stages. When you've collected 50 patients, 100 patients, 200 patients, you have more opportunities for being surprised if you think about it in this way. So if you assume the treatment has no effect, we measure how surprising our data are under the assumption that the treatment is ignorable. Or would you rather have the probability of all possible levels of efficacy? So that's a dramatically different way of thinking about it, because when you say, what is the evidence for any reduction in blood pressure or for a reduction more than 2 millimeters, 4 millimeters, 6, 8, 10, 20, those probabilities are probabilities about unknowns, and they're not assuming things that you don't know. So when you assume things that you don't know, like assuming the treatment has no effect, bad things tend to happen, and you have to worry about how often you're surprised under the assumption that the treatment doesn't do anything. So I'm going to go into that in a little more detail. So if you like the first approach, you like to calculate a measure of surprise given an unknowable assumption that the treatment doesn't do anything, then you are a frequentist. and you are a status quo person. So you're practicing statistical analysis the way most of us were taught. Going back in history, which I don't have time to do, when Bayes invented the field of Bayesian statistics in the late 1700s, he didn't publish it before he died. So he started out at a disadvantage, and it was slow to catch on. So what is the p-value? It's the probability of getting data that's more impressive than what you observed. Not data as impressive as what you observed, because the probability of that is 0. What's the probability of getting data more impressive than what you observed if the treatment is ignorable? That's a p-value. If you like the second approach, that's a Bayesian posterior probability, what might better be called current probability, and you have Bayesian tendencies. So what does a Bayesian posterior probability involve? A probability that an unknown effect is greater than some amount C, this could be a reduction in blood pressure, is greater than some amount C, given the data, given prior information, you calculate this Bayesian posterior probability. So the point is C here can be anything you want. If you put in 0, that would be meaning what evidence do we have for any blood pressure reduction? But we can put in any amount, and you could do this for 1,000 different levels of C. You can make this a graph. And so there's no such thing as multiplicity when you're just looking at different values of the amount of efficacy. So for example, you might calculate the probability of any blood pressure reduction, the probability of at least a 5 millimeter of mercury reduction, or a probability of similarity, that the blood pressure reduction between -3 and +3 millimeters of mercury, whatever you're defining as clinically similar. All those probabilities are calculated easily, and you can calculate as many of those as you want because you're trying to learn multiple things at one time. What's the evidence for no effect at all? What's the evidence for similarity of two treatments? And many other things. And this leads into a discussion of power and sample size. And the question, what are the most common outcomes of clinical trials? Well, the two most common outcomes, I think by far, are first of all, insufficient patient recruitment. And that's something statistics isn't going to solve. That's just something we all have to deal with. Does anybody know the median number of randomized patients in oncology? Over all of the oncology trials that are launched, what's the median number of randomized patients? The answer is 0. More than half of the oncology trials that are launched never randomize a single patient. So getting patients in is tricky, especially with uncommon diseases. The second most common outcome of a clinical trial is an equivocal result. So you have a planned sample size, and you get to that sample size, and you get a result that's not, quote, significant. And so when you get to that point, we have no knowledge. So it's a very common mistake, which is called the absence of evidence is not evidence of absence mistake, to assume that we did learn something when the p-value is small. You don't learn anything when the p-value is small, when the p-value is big, excuse me. Big p-values have no information in favor of the treatment not working. And what happens is the uncertainty intervals are too wide to learn anything about efficacy in the majority of clinical trials that do randomize patients. And so the main thing that you really learned is the money was spent. The money's now gone, but the knowledge didn't come in. There's no knowledge that we got for the money and time and effort that we spent, and plus we're exposing patients to. So that's an equivocal result, very, very common result. So you get a p-value of 0.1 when the study's done. What do you mean by that? Well, Fisher, who invented p-values, said the conclusion of a p-value 0.1 is get more data. So in other words, you can't make any statement right now, so it's a waste. It's a waste in a certain way of thinking. What are the most common causes of equivocal results? Over-optimistic power calculations. So we typically choose an effect size that we don't want to miss that's more than clinically relevant. And then if the treatment only had a clinically relevant effect, you're going to miss it. So you power a study to detect a miracle. You don't get a miracle, you're left with nothing at all. Very, very, very common result. And so this is really related to fixing the sample size and pretending that you really know the sample size. We also lose power in the belief that alpha is something that needs to be controlled when you're taking multiple looks at the data. I'll talk more about that. And then a major reason for equivocal results is an insensitive outcome measure, which I'll talk a fair amount about. So the problem with sample size is in the traditional domain of frequentist statistics, you need a final sample size to know when your alpha is spent. And also, you need it for budgeting. I don't know if you're like me, but I can't think of a single example in the last so many decades where I was involved in a sample size calculation where I did not feel I was prostituting myself while making the calculation. It is one of the most distasteful things that I've ever been involved in. And investigators come back, one investigator came back to me and said, I can't pay for that many mice. I know I wanted you to power it for a 50% reduction, but I think we can achieve a 100% reduction. So that's how she wanted to have 3 mice in the study in each of 2 treatment groups. So sample size calculations are truly voodoo. We have to set the type 1 probability alpha, the type 2 probability beta, or 1 minus the power, and the effect to detect. And if you have a continuous outcome variable, you need to know the standard deviation of that variable. If you have an event, you need to know the incidence of the event in the control arm in order to estimate power. That's asking a lot, and we're making it up. We just make this stuff up and hope for the best. So we're willing to roll the dice, spend $10 million or more on many studies, and hope for the best. That's just not good enough anymore. But until NIH changes budgeting, it's going to be hard to really solve this. The physics approach is to experiment until you have the answer. And that is, to me, so much more scientific and so much more realistic. So do you need a sample size? Yes, if you have a fixed budget. If you're using a Bayesian sequential design, you don't need to ever define a sample size. Somebody will probably make you do it. But there's nothing in the calculations and in the design that requires a sample size at all. Study extension is trivial because sample size doesn't mean anything. You get to your planned 200 patients and things are looking promising. The posterior probability of treatment benefit is between 0.7, but it's not quite to 0.95, and you thought that a 0.95 probability would be indicative of evidence for efficacy. You're between that, and so you decide that it's worthwhile to add more patients. Now, if you take a detour for 1 second and look at the learning health system, this is a golden opportunity, which we hope to do this a lot in, because in the learning health system, you don't have a budget, and you can keep the studies going as long as you want, as long as you think the results are going to be relevant to clinical practice. So that's a great place to implement this. What happens in the Bayesian approach, the reason there's no multiplicity in this regard is that when you're analyzing cumulative data, your sample size just gets bigger as you go along, and you're getting new results, new measures of efficacy evidence that just supersede your last analysis. So now you have 200 patients. The last time you analyzed the data, you had 150 patients. The analysis of the 150 patients is completely and utterly obsolete. There's nothing you need to do about the fact that you at one time calculated something else. The 200 patients now completely overrides our state of knowledge, and so there's nothing to calculate in the Bayesian world for the fact that you did look at 150 patients. So is alpha a good thing to control anyway? Alpha, people typically call this the type 1 error rate, and it's not a rate and it's not an error. Other than that, it's okay. But that's why I don't use those terms. It's the assertion probability. It's the probability essentially of getting a p-value less than 0.05 if there's no effect of the treatment, bad or good. So we're assuming there's no safety problem and there's no efficacy. Alpha is not the probability of making an error in acting as if the treatment works. It's the probability of making an assertion of efficacy, in other words, rejecting the null hypothesis, when any assertion of efficacy is by definition incorrect. So under the assumption of the unknowable being known to be zero, you can never know that, what is the probability of making an assertion of efficacy? That's alpha. And alpha is going to go up when the number of data looks goes up. So alpha includes the probability of things that might have happened, and that's where it goes wrong, and that's where it leads to scientific inefficiency. Even if you have very strong evidence of efficacy at a given time along the course of your multiple looks at the data, you now have a signal that's showing the efficacy looks very likely. You have strong evidence against the null hypothesis, in other words. Your design had the possibility of having impressive data earlier. Even if you analyzed the data earlier and the results were not impressive, you had the possibility that it might have been impressive. So in calculating your alpha, you have to penalize for the fact that it might have been impressive, even though we now know it never was. So how does it make sense to take into account what you intended to do instead of what really happened? So what Bayesian methods deal with is what did happen and not what might have happened. And that's why the probabilities are so straightforward and they don't need the kind of adjustments we have for frequentist p-values because of multiplicities. So I've got two analogies here. I think the second one may be a little better than the first, but using alpha is like judging how often a gambler makes a bet. That's not really how most people would judge a gambler. Most people would judge the gambler in the proportion of times she won when she did place a bet. We want to know the winning percentage. If you were a judge, a trial judge, and you brag to a colleague of yours that you have a low fraction of innocent people being found guilty by the judge over the years that the judge has provided in the courtroom, that judge would probably be disbarred. That's not a judge's job, is to look at long-term operating characteristics in the courtroom. So the Bayesian probability would be the probability that the current defendant is guilty. So we want that to be as accurate as possible. Controlling alpha leads to a conservatism when you're taking multiple data looks. And if you're doing a Bayesian design instead, you actually minimize your sample size by looking as often as possible. So the more often you look, the lower your sample size goes, because you have more opportunities to stop early with adequate evidence for efficacy. What happens with Bayesian results is they even stop earlier for futility than they stop earlier for efficacy. They allow you to quit wasting money earlier, but they're also useful for stopping early with evidence for efficacy. And so if you look after every patient, that would give you the minimum expected sample size. If you only looked every 100 patients, your sample size is going to be a multiple of 100, so it's going to be bigger. So what should we control? We should control the probability of being wrong in acting as if a treatment works. That's called a mistake. That's called an error. So that's a true error. Alpha is not the probability of an error. So this probability is 1 minus the Bayesian posterior probability of a benefit. And 1 minus the probability of a benefit is the probability of not benefiting, which means it's doing nothing or it actually hurts you. It actually raises your blood pressure. The probability of being wrong about the evidence of a treatment is controlled by the prior distribution and your data and the statistical model and the outcome measure and the sample size. Those all go into it. So an example, in time to event analysis, we often look at hazard ratios, and a hazard ratio less than 1 would mean that you're postponing death. So that's a good thing. So if you found that the probability that you're lowering mortality, given the current data and given the state of prior knowledge, is 0.96, then this 0.96 also defines its own error. So if you take 1 minus 0.96, you get the probability of inefficacy or harm. So if you were to stop the study with a 0.96 level of evidence for efficacy, by definition, you have a 0.04 chance of being wrong in acting as if there is efficacy. So 1 minus the posterior is the error, the complementary error probability. 1 minus the p-value doesn't mean anything. So the shocking truth about Bayes is it controls the reliability of evidence at the decision point. We're not asking you to look back of all the previous looks you took. We might have declared significance because we did 5 looks at the data. The fact that we didn't declare significance is of no consequence in the calculations in alpha for the frequentist world. So the Bayes says instead of that, what we need to be reliable is the action that we take at the moment of making the decision. We don't need to take into account any previous tendencies we had to maybe make a decision or previous opportunities we had. It's not relevant. So pre-study tendency for data to be extreme under an unknowable assumption that the treatment effect is exactly 0 is not used in the Bayesian approach. So a sequential design gains power by not having an alpha penalty, being directional. So if you're trying to show evidence for mortality reduction, you don't need to penalize yourself for possibly claiming lethality of the treatment. A two-sided p-value is actually a multiplicity adjustment for the fact that you might actually be seeking a different indication for your drug. You want it used in combat against the enemy, and you have evidence that it raises mortality. So we don't really make claims like that. So we need directional evidence, not bidirectional evidence. We allow for infinitely many looks at the data, and we can also borrow information when there is different treatment effect for, say, males versus females. We can make use of that without assuming males and females are arbitrarily different in their treatment effect. Now we get to the outcome variable, which is the place where you have a lot of control and you can do a lot of damage in designing a clinical trial. And so why do pivotal cardiovascular trials always need between 6,000 and 10,000 patients? The answer is not because it's cardiology and not because they're better funded, although they often are, but it's because it's a low information outcome that they're seeking. They look at time until major adverse cardiac event, which is just a binary event. And they don't distinguish a small myocardial infarction from death, and they completely ignore a death after a non-fatal heart attack. So by ignoring a lot of information and dumbing it down so cardiologists all over the world can understand what you did, they're actually sacrificing tremendous power and spending fortune on clinical trials. So we recently, a couple of years ago, completed the ischemia study. That was a $100 million grant from the National Heart, Lung, and Blood Institute. You're talking about real money to be able to do those kind of large cardiovascular studies. So if you wanted to do a study like that, you need 462 events to be able to nail down a hazard ratio with a margin of error of a factor of 1.2, which is not extremely narrow confidence interval, it's moderately narrow. So 462 events would do that, and depending on how rare your outcome is, 462 events might require 10,000 patients to be followed. That's why study is so expensive. Contrast that with a continuous outcome variable. How many samples would you need to estimate a difference in means to within 0.2 standard deviations? That would be 384 patients, not events, but patients. And if you went for the gold standard design crossover study, using each patient as her own control, to get the same quality of data, you would need only 96 patients. So the design matters, the granularity of the outcome measure really matters. If your incidence of the event goes down, your power is going to be reduced, and it gets to be the power of just having a binary simple outcome, which is your lowest power outcome. So we need to have some general attributes of outcomes. we need to look at the timing and severity of outcomes and handle various things. So we need to handle terminal events like death, non-terminal events like heart attack and stroke, and recurrent events like hospitalization. And this is not to mention things like biomarkers, quality of life, symptoms, functional status. Those also need to be handled. And so our goal is to break the ties. The more levels you have for the outcome variable, the higher the power. So your worst case would be everything is tied at 2 levels, alive or dead. That's your lowest power possible outcome measure. So we want to break the ties and have lots of gradations of outcome. How close to death did somebody come who didn't die? How close to living did somebody come who ended up dying? We need to have breaking of the ties. We need to have lots of levels to maximize power. Your ultimate power, high power, would come from having no ties in the data. If you're analyzing something like bone mineral density or maybe blood pressure, with very few ties in the data, you have maximum power. So what is a fundamental outcome assessment? Well, for a lot of clinical situations, it's the following. In a given week or a given day, what is the severity of the worst thing that happened to the patient? If you have consensus among the experts about which events are worse than whichever events, then these things are fairly easy to do. Sometimes you do a utility study, time trade-off, standard gamble, and you'll find that in some situations a debilitating stroke is considered to be worse than death by the patients, and you can take that into account. But assuming you can rank things in terms of order of severity to the patient, you can do this. The spacing of the categories is completely irrelevant. So we're not assuming that going from a stroke to dying is anywhere like going from no symptoms to having chest pain. There's no assumption about that. We're avoiding needing to define additive weights for multiple events at the same time interval. And you can grade events, and if you have common co-occurring events, you can just make that another event. So if there were a lot of people that ended up having a stroke and a heart attack, you would just make the combination of stroke and heart attack be worse than either one alone. So that's easily handled. You can translate an ordinal longitudinal model to analyze data like I just showed to obtain a variety of interesting clinical estimates, such as time until something happens. So what's the expected time until someone needs hospitalization? What is their expected time in the hospital? Over a 6-month follow-up, what is the expected number of days they needed to be hospitalized? That would be an example of expected time in a certain state. What's the probability of something bad or worse happening to the patient over time? That's a key way to look at outcomes, especially clinical outcomes. And this would be by treatment. And I'll show a graph of that. There's particular models for dealing with these kind of data, and one that we like is the Bayesian version of the partial proportional odds model, because one of the things you can do with this model is you can have non-fatal events and you can have a fatal event that you count worse than the non-fatal events, but you can actually calculate the probability that the treatment lowers mortality differently than the way it affects the non-fatal events. That's something you don't see in any clinical journal article, but you see people espousing about the so-called consistency of effect across different domains of outcomes and doing ad hoc analyses. Here you can do a very formal and meaningful analysis of consistency of the treatment effect on different events. This also elegantly handles partial information. And so if you're using time until something, like time until the patient was sent home, and you had a gap in the data collection, it's really, really hard to deal with that. But if you think about it as longitudinal data, where you measure it daily or weekly or monthly, you can handle partial information in an extremely elegant fashion, which I'll show you. So here's an example layout. Let's suppose you had the simplest situation where it's just alive or dead. And let's say you're measuring the vital status every week. So someone who dies, we're going to code that as a 1, alive is 0. So somebody's followed 3 weeks without dying, their raw data looks like 0, 0, 0. So you have this string of zeros, 3 weeks of follow-up, no observed death. Somebody that died at 2 weeks, they would make it alive through the first week, they died in the second week. So they have a 0-1 and they're terminated from follow-up because that's called an absorbing state of death. What if you had more levels? You had at home is your biggest success, but you also had hospitalized myocardial infarction or death. So somebody who is hospitalized at 3 weeks, they start off doing fine first 2 weeks. They're hospitalized at the third week. They're going home, and then in the 7th week, they're rehospitalized. They have a heart attack on week 8, and they stay in the hospital, and the follow-up ends at 10 weeks. So that would be what their outcome values look like. So that's a longitudinal follow-up design with ordinal status captured in each week. And it captures a tremendous amount of the clinical picture. You can see what it doesn't capture. It doesn't capture severity of the heart attack, which we have the most unbelievably hard time measuring in cardiovascular studies, but we need to measure that. What if you had quality of life as part of the scale? So let's say quality of life was 0 to 6, where 6 is poor, 0 is excellent, and you had heart attack, stroke, or death. And let's say that the quality of life varies and it was not assessed on week 3. You had missing data or you had planned not to collect it. You didn't have the patient interviewed in the 3rd week. So their quality of life is in week 1 is 1, then it goes a little bit worse to 2. In week 3, it's somewhere between 0 and 6. So we have no idea what the quality of life is because the survey wasn't done in week 3. So that's going to be interval censored. So we're going to make use of it being between 0 and 6. We know a clinical event didn't happen. So we know it's not a 7, 8, or 9. Now you have quality of life 3, 3, 4, 5, and then a stroke and then death. So that would be what your follow-up record looks like. You're capturing a lot of clinical information. You're respecting exactly what you don't know. If you were calculating time until event, you wouldn't know how to handle this, but with longitudinal data, you do. If the MI status was forgotten to be assessed at week 7, you would have this additional complexity. In week 7, we know they didn't have a stroke or die, and we know that if they didn't have a heart attack, their quality of life was a 5. So their observation in week 7 is either a 5 or a 7. And the analysis would make use of exactly that. What's the probability of getting either a 5 or a 7? That goes into our model, our analysis. You can also have lots of levels. So you could have 200 levels of a biomarker, and then you could have clinical overrides. So a good example of this would be you're measuring serum creatinine 6 weeks after hospitalization, and a few patients need dialysis, so you make dialysis the worst level, worse than any level of creatinine. It overrides the whole creatinine distribution. So that would fit naturally in this framework. So we like using the proportional odds ordinal logistic model, and we handle intra-patient correlation or longitudinal data with a Markov process or other longitudinal models. This is an extension of the regular binary logistic model. It's also an extension and generalization of the Wilcoxon test. There's no assumption about the distribution of the dependent variable for a given type of patient, and we're not using Y as a numeric variable. It's just an ordered variable like A, B, C, D, E. So you can interpret this as an odds ratio. Treatment B compared to treatment A has a better odds of not transitioning to a bad state. You could calculate the probability that somebody on treatment B has a worse outcome than somebody on treatment A, and that's related to the odds ratio. You can calculate the probability that the outcome is level Y or worse as a function of time in treatment. And so this is what that looks like. So let's say your outcomes had hospitalization, MI, or death as the only 3 outcomes. So this is the probability of being hospitalized or worse as a function of time and treatment. This is from the fitted model that you would fit on those types of data. And hospitalized or worse just means any event. Hospitalized is our least severe event. heart attack or death is going to be a lower probability, and death is going to be still lower. So you see you're accumulating severities of events, lower severities as you go from right to left. And your probability of death is going to be your lowest incidence event, and that's where you don't have a lot of power to study it on its own. But this will be a typical representation, and I'll show you a different representation. So there was a wonderful study to study the effect of vitamin D3 in acutely ill adults in ICUs, done by the Petal Network called Violet. It's the name of the study, published in 2019. And so they found who was vitamin D3 deficient and gave them vitamin D3. There were 1,360 patients. The study did not show a benefit for vitamin D. Vitamin D seems to get patients home faster, but also raise their mortality. But the so-called not significant increase in mortality. But they collected an ordinal endpoint each day for 28 consecutive days. It's an amazing data set. It's a beautifully designed and collected data. So this is what the outcome looks like for the first 14 out of the 28 days of follow-up. This is the proportion who are at home, so that's your best outcome. This is by treatment, placebo versus vitamin D. This is your proportion in hospital or in a rehab facility. The proportion needing a ventilator or having ARDS, and this is the proportion death. So you have a 4-level ordinal outcome assessed every day, and we'll do our best job by analyzing it exactly like it's collected. So that's a very common display that you're seeing for especially COVID studies, these sort of bar charts. They're very intuitive. Now, this is one way of looking at efficiency, and I'm just going to look at the top graph, but the bottom graph, you can see the axis goes 0 to 28 days here. This is the number of days sampled. So what if you sampled the ordinal scale at only one day? Let's say it's in the middle at day 14. That would be a pretty good day if you had to pick one. So the relative efficiency of that is a 1. In other words, every patient contributes one patient. What if you measured 5 days of outcomes uniformly dispersed between day 1 and day 28? So if you measured the outcome on 5 different days, you would more than effectively double your sample size. If you measured all 28 days for the ordinal status, this is almost 5-fold increase. In other words, if you have 1,000 patients in the study, the effective sample size is 5,000 patients. So having 28 days measured on the same patient has the statistical information of measuring 5 separate patients one day. So you can see that the longitudinal information in the data is quite large, and this will have power implications. So if you do simulations of the Violet study, and you do the analysis that NIH and FDA wants you to do, which we don't think is the best way to do it, it's time to recovery, the power of testing vitamin D versus placebo for how long it takes to recover, in other words, to get home, that power was 0.79. If you use this very common measure, this is used a lot at Vanderbilt, and I've been trying to talk people out of this for about 15 years because I think it has a lot of deficiencies. You do ventilator-free days, or in this case, ventilator and ARDS-free days, and you have to mark death somewhere, so the tradition is to put death as -1 ventilator-free days. Some people use 0. If you do a Wilcoxon test on that, the power is only 0.32. That's a pretty big loss of power by not respecting the raw data. And then if you respect the raw data and do a longitudinal ordinal model, the power is 0.94. So these are not really trivial differences. This is not just a statistician's fun and games. But this kind of difference here has a big effect on what sample size you need, or if you're needing to make early decision making in the face of a pandemic, you can make earlier decisions because your outcome variable has more information in it. So this is an ongoing discussion we're having with NIH and FDA, who doesn't believe you should really look at severity of symptoms as part of your outcome. So we're having that argument just about every week. But they're wanting us to power studies for mortality. In other words, they want to delay the study by 2 years during a pandemic. That doesn't make sense to me. So there's general principles for choosing outcome measures. You can increase power by breaking ties, getting closer to the raw data, making sure it's relevant to patients, and so on. You can also include safety events as part of your ordinal scale if you want to penalize for safety problems, such as lab abnormalities or side effects. Then a very brief discussion of covariate adjustment. This is where you get something for free. And it's amazing how often you're offered a gift and people turn down the gift. So covariate adjustment, a lot of people think about it in terms of adjusting for imbalance, and it really doesn't have anything to do with that. Covariate adjustment in a randomized trial has to do with outcome heterogeneity within a treatment group. Can you account for that? And if you adjust for strong baseline prognostic factors, you can increase the power quite a lot. And so you're getting the outcome model more correct. For example, we always have the case that older patients die sooner. But how many studies have you seen that did not adjust for age in their primary analysis? That's just about an unforgivable sin in terms of how to analyze data. You need to take into account that older people die sooner than younger people. And plus, there's a lot of other prognostic factors out there. If you're predicting 6-minute walk test, you need to account for the 6-minute walk test at baseline and adjust for that. And it also addresses the clinical question, which is if I had 2 patients at baseline who were like each other, except for the treatment they were given, does the patient who got treatment B end up better off than the patient who got treatment A? So you think about your gold standards as a crossover study. How would you make your parallel group study look like a crossover study? You covariate adjust, so you're comparing like with like. If I compare 2 30-year-olds at baseline on 2 different treatments, how much better does the 30-year-old on treatment B do than the one on treatment A? So covariate adjustment really does that. It also gives you the right basis for looking at heterogeneity of treatment effect. And if you had a continuous outcome that was explained half by one covariate, like age. So let's say you have an R squared of 0.5. So one covariate explains half of the variation in the outcome variable within treatment. That means your sample size is cut by a factor of 2 when you adjust for that variable compared to if you don't adjust for it. So there's so many clinical trials being done where the sample size is not big enough and then they don't adjust for covariates, and that makes it even worse off. We've seen a number of clinical trials in the past year terminated early because of recruitment problems because of COVID competition. And those studies have resulted in an inconsequential result, whereas if they used a high-powered design, they might have had a definitive result. Change from baseline is another way to lose power. So if you ever analyze change from baseline, you're asking for trouble. It only keeps power under a set of very restrictive conditions. In general, you will lose power by analyzing change from baseline as opposed to doing covariate adjustment. So the take-home messages are, don't take sample sizes seriously. Consider sequential designs with unlimited looks at the data and possible study extension. Alpha is not a relevant quantity to control or spend, although there will be people at NIH and FDA to try to tell you otherwise. Alpha is not relevant because it has no relationship to decision errors. Alpha is just a probability of asserting an effect. Choose a high-resolution, high-information outcome variable, dependent variable. Longitudinal ordinal outcomes are a very flexible way to handle many different types of outcomes, including recurrent events like hospitalization. You always adjust for strong baseline prognostic factors and don't stratify by treatment in Table 1. And if you want to know why, you can ask me later or look at a blog article about that. So thank you all for listening. There's some other resources here that you might want to look at, and I think we have some time for discussion. Steve.
You can't hear it unless I'm on this. So it's not that my question is important. All right, so you're like the Delta variant. I'm totally infected, and I agree with you completely. The challenge that we have, and this is based on study section experience, is that I can talk about this stuff even as a study section chair, and it's just impossible to say something like, you know, that power analysis doesn't make any sense. I mean, all these things. So this is so incalculated into our culture of science, and I know I hear that you're having this problem, you know, with FDA, and so I got to tell you, you know, if you come forward with these designs and you have someone like me in the study section, I'm going to say yeah, but you're going to have a whole bunch of other people that just aren't going to be on board with this, and it has to do with paradigm shift. It has to do with so many things. So I'd love to hear your comments on this.
Well, it's the toughest problem of all, is getting people to unlearn what they've already learned. And Churchill said it best when he said, never, ever, ever give up. So that we keep fighting. And then the other person that said something useful here was the physicist Max Planck, who was asked, how do you get people to change? He said, people don't change, they just die. And you wait for them to be replaced by the next generation.
But they got to get funded now. Yeah. No. Yeah.
Hi, Dr. Harrell. This question comes to you from someone that's viewing virtually, Shanna Arnold-Egloff. Her question is, Dr. Harrell, thank you for beautifully simplifying Bayesian design. Can you comment on the limitations or issues that can influence inappropriate early stoppage due to futility or efficacy? In other words, can early stoppage be wrong, and in what circumstances? Example, the C3P0 study for convalescent plasma in COVID-19 was stopped early due to futility, but further evaluation showed that randomization failed, leading to biased selection, erroneous results, and inappropriate early stoppage.
Yeah, that is a set of questions that are all wonderful. And so I'm just going to pick one little bit of that. When you're doing a futility analysis, there's more than one way to do it, and it's critical how you do it. And so there's a lot of parameters to set in futility. How much evidence do you need? And how often do you look at it, and sort of thing. So it's very important. But just in terms of how you can be misled in the other direction, if you're using regular frequentist approach and you stop early for efficacy, it's well known that you will overstate the efficacy. If you're using a Bayesian approach and you stop early for efficacy, you get it exactly right. So I have a blog article that goes into detail about how when you calculate the posterior distribution, when you stop it early for efficacy, the efficacy estimate is drawn back according to how early you stopped. It's automatically handled. So that's another advantage of the Bayesian approach.
Hey, Dr. Harrell. This question may reveal some shocking lack of knowledge in statistical design here, but as a clinician scientist, who's worked with extramural funded statisticians in the past, I'm trying to understand almost a contradiction I feel like I'm getting from one of your big take-home messages. If there's anything that I feel like I've learned from statisticians that I've worked in the past, as a clinician who's eager to run a complex multivariable model to get a result that's going to get published in the New England Journal, it's that there's a risk of overfitting the model when including too many covariables, and it's almost, but what you're explaining is that by including relevant covariables, it actually increases the power. Can you clarify?
Oh yeah. So when you're doing covariate adjustment, and I have a chapter about this in an online course, it's really important to pre-specify the covariates you're adjusting for. And if your sample size is small, you cannot adjust for as many as if the sample size is large. There's some very rough guidance about how many covariates you should try to adjust for depending on the sample size. So typically we adjust for 5 covariates for moderately sized studies, but probably less than that for very small studies. So it's definitely a point worth drilling down about.
Frank, considering the Bayesian approach to clinical trials, what advice would you give to a DSMB where at an interim analysis there is evidence of efficacy, but it's not strong enough to actually change clinical practice? Or to put it another way, is it ethical to continue a clinical trial when there is some evidence of efficacy, but not as much efficacy as we would like?
And the companion question to that super question, Bill, is you may have evidence for some efficacy, but you have no idea how much efficacy. And is that a reason for stopping? Most clinicians would probably say, no, that's not enough for stopping. So I think it's a key problem, and it's really hard to solve. If you really knew all of the consequences of the decision, you would write down all the consequences and make a loss function or a utility function. Say, what's your cost of not getting a useful drug out there? What's your cost of putting out a drug that doesn't really work? What's your cost for getting 80 more patients accrued? How many dollars is that? You can have a cost function, and you can optimize the cost function or utility function using a formal Bayesian decision. So one example in the literature was there was a vaccine program in a Native American reservation, and there were people enrolled in the randomized trial, but the cost, the utility function was how many people in the whole reservation contracted the infectious disease. So the utility function was a community-wide function, whereas the efficacy assessment starts with those who were only in the study in the reservation. So it's just an example how you can actually do formal decision-making with Bayes if you could ever specify the different costs or consequences of those things you just named, which is the hard part.
Thank you for your talk. So I think the ordinal outcomes is very helpful. Then can you comment on the composite outcomes? In many CVD trials, they combine the death, MI, stroke as a MACE, the major adverse cardiovascular events, as an outcome. How does that compare to the ordinal outcomes?
That's a super question. I'm sorry I didn't actually get explicit about that in the talk. But the major adverse cardiac events has major problems because you're counting hospitalization the same as death, you're counting a heart attack the same as death. And if somebody has an early heart attack and then they died 4 years later, the death is completely ignored. If they have an early heart attack and they die 1 day later, the death is completely ignored. So any method that ignores deaths, you have a suspicion there's information there that's being ignored that shouldn't be ignored. And also, by not breaking the ties and by counting hospitalization equally bad as a stroke or death, you're losing power. So you're going to gain power by breaking the ties and considering some things worse than other things. So major cardiac events is a recipe for spending money. So if you want to spend the maximum money, that is the outcome for you.
We have an online question.
Okay, this one comes from Eric Tagzik, and the question is, could you speak more to how modern ordinal versus traditional binary approaches are affected by uncertainty in the outcome/level of outcome?
That's a good question that I haven't done justice to in my career. But I would say, just speaking in general, the fewer categories that an outcome has, the more measurement error hurts you. Because if you have 2 categories and you put somebody in the wrong category, that's a 100% relative error. If you have 5 categories and you put them 1 category away from where they should be, that's like a 20% relative error, roughly speaking. So in some ways, having more categories actually reduces the consequences of measurement error. It doesn't reduce the frequency of error. It may make the frequency go up, but the consequences go down.
Thank you for a great talk. Many of us are bench scientists, so do these methods have any role in mouse studies, cell studies? Do I have to learn Bayesian statistics now?
I think everybody should learn Bayesian statistics. And I went to a conference on acute kidney injury at NIDDK several years ago, and a speaker who is an expert in dog studies of acute kidney injury said the number one explanation for the non-reproducibility of dog studies in acute kidney injury is the sweeping under the rug of deaths that occur to the dogs while they're on study. Most of the published studies publish the results on the surviving dogs. So they didn't know what to do with the deaths. So if you had a certain amount of kidney injury, but you counted death as worse than that, it's not a perfect solution, but it would be a lot better solution than just putting the deaths under the rug. So that's just one example how using a more complex outcome measure can help. You don't have to put anything under the rug anymore, as long as you know where to count it if death is really worse than the other outcomes. And then Bayes will help in general.
Thanks so much for that great talk. One question I had for you was, so when you talked about how precise you can get with the ordinal measures and, capturing week by week, and I can understand it when you explain it kind of person by person. How do you get over the challenge when you're presenting the results for a really big trial and that, essentially could be thousands and thousands of outcomes like that, right? Or I guess if you had 1,000 patients and then you had all of those lines, I guess you did show that figure where, with kind of the bar graph. Is that basically how you kind of communicate the data? Because I can kind of see how people, the traditional way of doing things, while it obviously has its setbacks of, losing a lot of power, I think people can wrap their mind around 20% less or less hospitalizations, death, stroke, though we discussed all the limitations with that. But then when you have such a beautiful outcome like that, it's really complex. How do you kind of communicate that to the average scientist who isn't an expert in Bayesian methods?
Another good question. I think those bar graphs will work if you have, say, no more than 20 categories or maybe 10. But your point comes in when you have lots of categories. So what you could do is to show a bar graph that oversimplifies it down to, say, 20 categories, where you put some of the more continuous levels into intervals. But then you quote to the reader, let's say you had serum creatinine as your outcome, and then you had death overriding that. Or let's say you had dialysis overriding that, and then you had death overriding dialysis. So you could say, what's the probability if you're on treatment A that your serum creatinine was greater than 2, or you died or had dialysis? What's your probability that your serum creatinine is greater than 2.25, or you die or have dialysis? So you could give all these different probabilities, but you notice the or is always there because you're not sweeping the other events under the rug in any way. So you would have to pick some example points along serum creatinine to do that, and I think you could do it.
One more online from Hada Al-Khaldi. If I have a certain sample size, would the stratifying analysis based on gender adjustment, I'm sorry, I have to kind of, if I have a certain sample size, would the stratifying analysis based on gender or adjustment for gender change the power?
Yeah, the thing that changes the power the most, if you want to assume that there's no commonalities between male and female in their response to treatment. So if you have separate strata and you analyze them separately, you're allowing them to be arbitrarily different, which is the same as putting them together in one analysis and having a treatment by sex interaction. So if you have a treatment by sex interaction, that is the way we usually do it, your sample size goes up by a factor of 16. So if you wanted to be able to make a statement about sex-specific treatment effects, your sample size goes up, somewhere between a factor of 4 and a factor of 16. It has a huge consequence. Bayes comes to the rescue because Bayes would say, we're going to assume that the females have a response to treatment that's more similar to the males than they are different. So we're going to have an interaction in the model that's half in the model and half out of the model. And by putting a restriction on the interaction to only allow males and females to get customized efficacy estimates as the sample size gets very large, But when the sample size is not large, you're going to borrow information from the males to the females. You'll quit hurting yourself by trying to ask a nuanced question about differential effects by sex by having a Bayesian prior distribution on the interaction effect for age and treatment.
Any other questions?
Thanks for having me.